So good evening to everybody. I'm Andreas Panagopoulos from Patras University. Me and my moderator, Emmanouil Brilakis from Athens, we will organize a webinar about the simple elbow dislocation that it's sometimes not very simple. We have a very good panel of speakers, Christos Koukos from Germany, Roger Van Riet from Belgium, Adam Watts from England, and Zinon Kokkalis from Patras to present you why a simple dislocation cannot be very simple sometimes. So we can start from Christos Koukos about the classification of acute elbow instability. Thank you very much for watching.
Thank you for the nice introduction, Andreas. Thank you, Andreas and Manus, for the invitation. So as you said, I'm going to talk about that classification, or maybe it's even better to say classification, but it's more than one that we have in the staging of the simple elbow dislocation. I have no disclosures. The anatomy is, of course, really important to know, especially for the medial and the lateral side, because we have all the elbow stabilizers that play an important role. These are divided into the static and the dynamic stabilizers. The static ones are classified into the primary and the secondary constraints. The primary ones are the ulnar-humeral articulation, the anterior MCL, which is a great valgus stabilizer, and the lateral collateral ligament complex. On the other side, we have the secondary constraints, the radiohumeral articulation, the common extensor origin, and the common flexor origin. What I would like to say about the dynamic stabilizers is the anconeus plays an important role in the posterolateral rotatory instability, and he is a varus stabilizer at the same time. What we actually have to find out all the time is what is injured. Is it the LCL complex? Is it the MCL? Is it both? Is it the capsule and the tendons? Because we actually know the higher the degree of tendon and muscle injury that we have, the greater the instability that we have. So the mechanism of injuries that we have in elbow dislocations is mostly the valgus posterolateral that we're going to talk about in a bit, and all the theories behind it. And on the other side is the varus posterior medial rotatory instability, where we see an LCL tear and a fracture of the anterior medial facet of the coronoid. And I have to stress this because I'm a great fan of the PMCL, a rupture of the PMCL at the same time. The theory for the valgus posterolateral instability has prevailed all these years from 1991 has been described by O'Driscoll. It's what we all know as a Horry's circle, as a fall with an outstretched arm, and as soon as the impaction takes place, it comes into a slight flexion at the same time in an external rotation and a valgus moment at the same time. That gives us three stages. Stage one means that we have a rupture of the LCL complex, or sometimes even just the LUCL, as you see on the bottom picture. Stage one is the PLRI. Stage two, we have a complete rupture of the LCL complex and a capsule rupture, and common extensor origin, either partial or complete rupture, that gives us the perch position, this subluxation, and that's stage two. And three is classified into A, B, and C. A is an incomplete tear of the MCL. Stage B is a complete tear of the MCL, and what 3C is an avulsion or a tear of the common flexor origin from the medial epicondyle. There is, though, another theory that has been more promoted, if you want to say, if you want to put it like this, by MRI studies that actually showed that the mechanism is a bit different. So there is a valgus moment in the hyperextension. It's the so-called valgus hyperextension mechanism. There is even a video analysis by Schreiber 2014 that he actually shows that the sequence, the injury sequence, goes the other way around. So we get the medial ligament first torn, followed by lateral ligament tear, common flexor origin, then anterior capsule, then common extensor origin, what gives us this latter concept of soft tissue involvement described by Robinson et al. It's Adams group 2017. You want to divide the elbow dislocation according to direction. I have to say the posterior ones prevails 90%, and mainly the posterolateral elbow dislocations, as we see on the right side on this X-ray. Of course, we have more types. For example, as you see on the left side, the anterior one, even though I have to say here, the anterior one, it's uncommon to see without a fracture. The second one from the bottom as the divergent is a really rare dislocation that we see mostly in pediatric patients. And the radial lateral one, where the radius and the ulna migrate or dislocate to the lateral side or radial side, or on contrast, the ulnar dislocation, where they actually dislocate to the ulnar or medial side. Of course, we can classify them into simple elbow dislocations, where we're talking about today, and the complex elbow dislocations. The complex elbow dislocations are one with fractures, and the fracture dislocations, what we're not talking about tonight. On the other side, the simple dislocation, one without fracture, but as again, that's from Adam's team, Singh et al. Like 2020. He included in simple dislocation the periarticular avulsions of less than 2 millimeters. Having said that we can proceed with the most recent classification that we have, that so-called Polestar, has been described by the group of Paolo Arrigoni, that shows the fragmentation pattern of the posterolateral aspect of the capitellum, and it shows additionally that the more the volume of the fracture fragments that we have, the more the radial head tends to engage into the posterior capitellum and a dislocation. That's why he classified these two types, the fragmentation type, type 1, where there's a present the small bony fragments, and type 2, the impaction type, where there is a bony defect in the posterolateral aspect of the capitellum that is matched with the anterior radial head profile. He actually divided these posterior and posterolateral elbow dislocations according to the trauma pattern. Grade 1 was a simple elbow dislocation. Grade 2 was elbow dislocation with a fracture of the coronoid tip. And grade 3, it was an elbow dislocation with coronoid tip fracture. At the same time, radial head fracture less than 1/3 of the radial head when you see in a lateral view. And grade 4 was a terrible triad with, though, a partial involvement of the radial head, but more than 1/3. The fragmentation type, as you see it here, with this small bony fragment as a bony avulsion in the LUCL, and you see the mechanism, the external rotation and supination of the radial head, and the posterior migration that causes this bony avulsion here. On the other hand, the impaction type, type 2, we see the bony defect because of the engagement in the posterolateral aspect of the capitellum. It's what we all know as osponcotural lesion. And at the same time, the involvement less than 1/3 of the radial head here. And this is the mechanism where we see no avulsion in this case, but we see once the radial head is supinated or externally rotated, and then it engages in the posterolateral aspect of the capitellum. So what he found out, like in grade 1 and 2 elbow dislocations, the fragmentation type prevailed in comparison to grade 3 and 4, where the impaction type increased even more and more. Last but not least, we can divide, again, the elbow dislocation in acute and chronic. The literature here is not clear. And according to Donoghue and Malhoff in 2016, they defined chronic elbow dislocation, one that hasn't been reduced for more than 2 weeks. On the other side, though, Dalowiski in 2014, he showed no difference in primary repair if you do it like in more or less than 30 days. But again, on the other hand, we have Sanchez Sotelo in 2005 that he showed actually that he had better results with reconstructing the ligaments than doing a primary repair. If I'm allowed to actually add here my personal preference, as what I consider acute is less than 3 weeks. Subacute is what I say the gray zone, 3 to 6 weeks, and chronic more than 6 weeks. But again, that is my personal preference and opinion. In conclusion, classifications are important for us to analyze the injury mechanism, then in order to be able to state it, and that helps us decide for our further treatment. Thank you very much.
Thank you very much, Christos, for your presentation. I would like to greet every one of you for being here. And from my turn, I also want to mention that you can use the Q&A button and ask your questions in order to discuss them at the end of the presentation. So with no further delay, I would like to present Professor Adam Watts from UK, and he will be present the clinical and the radiological assessment of instability after closed reduction.
Thanks very much for that, and thanks for the nice introduction. Welcome everybody. Good evening. So by way of disclosures, I need to make these disclosures before I start my talk. None of these are particularly relevant to the subject that we're discussing tonight. So simple dislocations, they're unpleasant injuries. What do? Do we run away with holding our head in our hands like the guy in red, or do we, like the guy in black, make it somebody else's responsibility and point and walk away and ignore the injury? Well, unfortunately, we're the elbow guys and girls, and it's our responsibility to sort these injuries out. It may be that you've got somebody who's hard as nails and you just need to reduce them, strap them up, and then send them back out to battle. And maybe, you know, for some that is manageable, but look at the expression on his face. He's not entirely convinced, and possibly at the end of the day, he just wants to give his opponent a big hug. So, of course, when we see the patient in the emergency department, we want to get a radiograph. It is helpful to get a radiograph before reduction to make sure that it is a simple dislocation, that there isn't a fracture element to it, and we're not going to make things worse by attempting a closed reduction. It also tells us about the direction of dislocation, which can give us some useful information when we subsequently come to manage the injury. It would be really helpful if those doing the reduction had some understanding about simple elbow dislocations and the work of Schnetzke's group to assess the stability of the elbow at the time of reduction, because actually that's when we can get the most useful information. Schnetzke showed that if you have more than 10 degrees of gapping either on the medial or the lateral side, then there's an 8-fold increase of recurrent instability, and therefore there may be an argument for earlier surgical intervention in those patients. But certainly there is useful information to be gleaned, and we'll come back to talk about that in a moment. The reality is, what we tend to see is the patient coming to our clinic with a very swollen elbow, having had it reduced,
They probably in a back slab and certainly in a sling. And we have a radiograph like this showing the elbow congruently reduced. We're trying to discourage the use of back slabs because, of course, they act as elbow distractors. But all too often, the patient still attends in that way. And can you really glean useful information from examining an elbow in that situation, where, regardless of the grade of injury, it's going to be very sore, it's going to be very swollen, and really quite difficult to address? So we turn to the literature to tell us how to try to manage this injury. And systematic reviews should say that non-operative treatment is the standard of care. So, and early mobilization should be the key. And they state that there is no clear criteria to recommend, clinical criteria to recommend surgery for these patients. So we get them moving. And the FUNCSI trial from Denise Eigendahl has shown us that immediate mobilization leads to a quicker recovery compared to delayed mobilization. Delayed mobilization with essentially the same outcome at the end. And they reported no episodes of recurrent instability in this non-surgically managed trial. However, it should be noted that those patients were screened, so they'd excluded patients with what they deemed to be unstable elbows, although it's not entirely clear how that decision was made. So overhead mobilization will neutralize the forces across the elbow and keep the forearm on the end of the humerus, and importantly will switch biceps off. And Graham King's group have shown nicely how that helps to keep the elbow on the forearm on the end of the humerus. But there's a problem. If we look deeper into the literature, we can see that about 40% of simple elbow dislocations go on to have persistent elbow stiffness and pain, and about 1 in 10 patients go on to persistent symptomatic instability when we ask them about their symptoms in the long term. So maybe that non-surgical management is not quite as simple, and we need to try and get a better understanding of the injury that we're faced with. If we look at population studies, this is from Ontario in Canada, nearly 5,000 cases. They had a relatively low rate of needs for further surgical intervention, the most common being further stabilization surgery, treatment of stiffness, and a low rate of total elbow arthroplasty. And although these percentages are low, they're still means we're looking at 200 to 300 patients from this group, and that's important to understand that actually sometimes it goes wrong. They identified some risk factors for further surgical intervention. They identified initial reduction in hospital as a risk factor for requiring further stabilization. Maybe that's because of the severity of the soft tissue injury. And for those requiring arthrolysis for stiffness, we can add on to that initial reduction by an orthopedic surgeon or multiple attempts at reduction. So an elbow that keeps dislocating and therefore is unstable and goes on to stiffness. And it's important when treating post-traumatic stiffness of the elbow to always consider that hidden cause of stiffness, which is instability, which can be a problem. So in my practice, we treat a lot of rugby players, and they come to us with hyperextension injuries and simple dislocations. And this is a really good model for us to understand what goes on with elbow injury, simple elbow dislocations. Clearly, this is a population where neither they nor I could run the risk that they were going to go on to having further instability. So for this population, I would routinely do an MRI scan. And initially in my practice, I took them all to the operating theatre and did an examination under anaesthesia. And what we discovered was that there is a spectrum of injury, depending on how much force is put through the elbow from the teammate coming in from behind onto the back of the elbow. And what we also found was that the injury started on the medial side. So this is a hyperextension and valgus injury where the medial ligament tears first, then the injury spreads to the lateral side of the elbow. And this taught us a huge amount about simple elbow dislocations, and the fact that it's a model for the injury, depending on the amount of force that's put through it, that affects the extent of the soft tissue lesion. So we then started to think, well, maybe the same is true for simple elbow dislocations. And there was some evidence from the literature, from Schreiber's group, showing, again, that the most common injury in the simple dislocation is a medial ligament injury. Yes, some of them have injuries to the lateral sided structures, but most common, the problem is on the medial side. And the same group also showed, from watching YouTube videos, that the mechanism of injury is much like our rugby players. They're valgus hyperextension injuries in the vast majority of cases. So our rugby playing elbows with their hyperextension injuries to the elbow is a useful model for when we're managing this type of injury. And here you can see the elbow is in extension, goes into valgus, and the elbow dislocates, and almost certainly a posterolateral dislocation of the elbow that this wrestler has sustained. So we conducted a prospective study of all the simple dislocations coming to the clinic, and what we found was exactly the same pattern of injury as our rugby players. So the injury starts on the medial side. You tear, every case has a torn medial ligament. Some have lateral ligament injuries, most have lateral ligament injuries, then common flexor origin, and then common extensor origin. That's for posterolateral dislocations, which is about 90% of the injuries. And so we thought that maybe there's this injury ladder that we can describe for the extent of the soft tissue injury, and we can create a grading of simple elbow dislocations from those with isolated medial ligament injuries, grade 1, up to grade 4, with common extensor tendon avulsion. And what we learnt from our rugby players was actually the ones that probably need surgery are those that have grade 4 injuries. Grade 1, 2, and 3, you can almost certainly treat non-surgically, and that's certainly become my practice. So the MRI scan has been useful to help us to understand the nature of the soft tissue injury, to stratify the lesions, and then decide how to manage the individual that we're faced with. And we tend to start fixing on the lateral side to downgrade the injury, bringing them down the ladder one rung at a time, and we go to the medial side if they're still unstable. But randomized controlled trials which suggest that actually surgery is of no benefit in simple elbow dislocation. So this is the only one that I'm aware of from Josephson, 30 patients randomized to surgical or non-surgical treatment and no difference in outcome. But of course, if we accept that only 10% of injuries are grade 4 injuries, then we're never going to see a difference in a randomized controlled trial where we include all simple elbow dislocations, because 90% of them don't benefit from surgical intervention. But the question is, what about that 10%? The one really important thing that Josephson taught us is that the predictor of instability is the tendon injury. It's not the injury to the ligaments. And of course, that makes sense when we consider the joint reaction forces across the elbow from the muscles crossing the joint, which produce a resultant moment pulling the forearm. And here, if the green arrows are removed, then we have a potential for varus valgus instability. And that's really the basis for Schnetsky's screening examination of the elbow. And if the joint gaps by more than 10 degrees, that means that almost certainly the tendon is avulsed. And people say to me, well, how do I know if it's 5 degrees, 10 degrees, or 15 degrees? Well, it's pretty dichotomous. Either the joint gaps just slightly, but then you reach a reasonable firm endpoint. That means the ligament's torn, but the tendon isn't. Or it just keeps going as you put a valgus or varus force on, and then you can assume that the tendon's off as well. So an EUA with fluoroscopy is a reasonable screening tool, or as in my practice, you can use MRI scan. So this patient on the left, a grade 1 injury, isolated medial sided injury, I would leave alone, immediate active mobilization and expect a good outcome. Whereas patient B with a grade 4 injury where the tendons and ligaments are off both sides of the elbow, I think they're going to be highly unstable when I take them to theatre and do an EUA, and I'm going to operate on that. We don't have a randomized control trial that's stratified to inform us, but we have some indirect evidence from Lars Adolfsson, who showed that patients who go on to have recurrent instability of the elbow after simple dislocation, if it's a posterolateral injury, they have a high degree of soft tissue injury around the elbow. So basically, they're grade 4 injuries. But what he also showed was that there's a disproportionate number of posteromedial dislocations, and that's important because it's a different injury. You have a more extensive lateral-sided injury, and the lateral-sided soft tissue structures are important, and therefore they're much more likely to go on to recurrent instability. And of course, they do follow the Horry cycle as described by Sean O'Driscoll, and the injury seems to start laterally and travel medially. And those ones tend to run the risk of recurrent instability and PLRI type problems, although most recurrent instabilities after a simple dislocation are frank dislocations rather than PLRI. Look out for the Osborne-Cotterell lesion, as Inho Gion highlighted, and we've drawn attention to the anatomy of this posterolateral ligament. So that Osborne-Cotterell lesion is an osteoligamentous avulsion injury and contributes to instability of the elbow. And of course, sometimes they're very large lesions, as in this case, and you can actually get an engaging Osborne-Cotterell lesion contributing to instability. Look out for a loose body that's got trapped in the joint and is preventing reduction, because that's an indication for surgery. You'll see that on advanced imaging, and you can treat that with arthroscopy and then stabilization. So in my practice, I use MRI scan to stratify the injuries. If it's a grade 1 to 3 injury, they're treated non-surgically. If it's grade 4, then we do an EUA and stabilization if it's unstable. It's helpful to bring the C-arm from the opposite side of the table, and then you can lift the arm into the beam. And we normally pre-infiltrate. We start on the lateral side, fix the lateral ligament, then go to the medial side, fix the medial ligament if it's still unstable. And of course, as soon as you cut through the skin, you're going to fall into the elbow because all of the structures are torn. So the key take-home message from my talk tonight is that simple dislocations are not all the same. Posteromedial dislocations are more likely to have instability than posterolateral. And the posterolateral, the most common injuries, have different grades of soft tissue injury. So you have a choice. You can either do an MRI scan or an EUA for everybody, which is what I do, and then try and work out from that which ones might need surgery. You can look at some predictors, so significant pre-reduction displacement might be an indicator of more extensive soft tissue injury. An incongruent elbow post-reduction is bad sign. The patient who's reluctant to move the elbow, that can be misleading, but it may be a sign of an more unstable elbow. But do look out for bruising on the lateral side of the elbow, because normally the canvas, the tough canvas on the lateral side of the elbow, the fascia, is not torn in a simple dislocation. The hematoma is trapped underneath. If that's torn on the outside, the hematoma escapes. That is an indication of a more high-grade injury. So you may say, well, I can't MRI scan or EUA every simple elbow dislocation that I see. Well, it's not that common. Again, the study from London, Ontario indicates that the incidence of this injury is about 3 in 100,000 of your population per annum. So it's not that common. You're not going to melt the MRI scanner by requesting scans. But there is an alternative. If you can either try to stratify the injury, or you can just accept, I'm going to treat them all non-operatively. Some of them are going to run into trouble, and maybe then those are the ones that I'm going to come back and do something later. And maybe they will do fine. And you have to decide what works best for your population. Thank you very much indeed.
Thank you very much, Adam, for this excellent presentation. And now we go on with Zinon Kokkalis from Patras about the conservative treatment of simple elbow dislocation and the complications.
Good evening, everybody. I want to thank the moderators for including me in this nice panel. And my task
is to discuss about the outcomes and complication of the conservative management. I have no disclosure with this presentation. We know that conservative management is the mainstay of management after close reduction of a simple elbow dislocation. Traditionally, the elbow is placed in a plaster of Paris, cast for a few weeks after close reduction, followed by physiotherapy. And let's discuss after close treatment what the literature says. Then what? We put the elbow in a posterior elbow splint, just collar and cuff or sling, a hinged elbow brace, and then we start to mobilize the elbow early or late. So let's see the literature. This is a nice study in French that was published in 1999. A randomized prospective studies of 50 cases that were randomized in 24 patients that mobilized in a plaster, 26 allowed it for early mobilization. In the early mobilization group, functional therapy was begun on day 3, and from this study, at the 12 months of follow-up, there was an extension deficit in 4% of the early mobilization patients versus 19% in the immobilization group. These authors concluded that immobilization of the elbow must be short-term and rehabilitation must be started as soon as possible. Another study who compared two different methods of treatment after close treatment. 20 patients were treated, mobilized by plaster of Paris, 22 by a sling method, follow-up 2 years. From these studies, they found that the DAS score in the sling group was much better than the plaster of Paris group. Also, the sling group returned after 3.2 weeks to work, as compared to 6.6 weeks for the plaster of Paris group. In this series, early mobilization did not result in redislocation or late instability of the elbow, and they concluded that the final outcome of the sling and early mobilization group was much better than the plaster immobilization group. Another study that Professor Adams has already mentioned, from results, it's a multi-center randomized controlled trial from Netherlands. They studied 100 adult patients, early mobilization 48 patients, 3 weeks plaster 52 patients. They studied with their functional scores, and patients were followed for 1 year. And the findings from this randomized study are that early mobilization is a safe and effective treatment for simple elbow dislocation. Early mobilization does not increase the rate of complications, and these authors suggested that plaster immobilization must be abandoned for the treatment of a simple elbow dislocation, and motion exercises should be started by a supervised by a physical therapist. What type of physical therapist? According to this study, for 27 patients that treated non-surgically with an overhead motion protocol designed to convert gravity from a distracting to a stabilizing force, motion was initiated within 1 week of injury, mean follow-up 21 months. Range of motion was very good, also for flexion, extension, and pronation supination. No recurrent instability was observed in this series. All patients were functionally without any limitations. And these, the same group of authors from New York, have already published a biomechanical study, a cadaveric study in Journal of Shoulder and Elbow in 2013. And according to this study, the overhead motion protocol is a safe protocol for stable elbows. The supine position results in the least amount of unlohumeral distraction across flexion angles from 10 to 90 degrees. And these authors recommend not to use the hinge elbow brace after elbow dislocation. And I'm going to discuss about some outcomes after close reduction in the literature. This is a paper in JBJS 2011 with a very long follow-up, 7.3 years, 110 patients. They studied these patients with functional scores and also with range of motion. In this study, 80% of the patients treated with a posterior spleen for 1 to 3 weeks. Only 10% they used no mobilization, and 5% were mobilized for a longer period of 4 weeks. Multivariate analysis demonstrated that loss of elbow flexion and female sex were both independent predictors for poorer functional scores. And very interestingly, 56% reported stiffness, 62% reported residual pain, and 80% of patients reported subjective instability. So these authors concluded that a simple dislocation of the elbow is not necessarily a benign injury. And here is another recent study that shows very promising results after conservative treatment from Thomas McKinnon, UK, England. And they studied 71 patients with mean follow-up almost 20 years. The primary outcomes were change in the Oxford elbow score and the DAS score over time. Secondary outcomes were change in the elbow range of motion and level of patient satisfaction. Also, cases of secondary surgery were collected. These authors showed excellent results in both men and women for all the functional scores and the satisfaction of the patients. From this series, number of the patients had undergone secondary surgery for instability during this interval period, and then concluding that the original excellent outcomes following treatment with a supervised protocol remained excellent and were maintained into the very long term. Another study that they compared the surgical versus no-surgical treatment, 47 patients, 21 patients conservatively, 23 surgically, 24 months follow-up. Outcomes were similar. No difference in elbow stability and laxity as measured by ultrasound. And complication rates was more in the surgical group, 21.7% as compared with the conservative group. And this is the systematic review from Charlotte Pott that was published recently in JBJS Reviews. It's a systematic review of 37 articles that were included with 1,081 dislocated elbows. Outcomes were assessed, including range of motion, patient-reported outcomes, and complications rates. In this study, non-operative treatment was done for 710 elbows, 244 elbows treated with early mobilization, 239 with 1 to 3 weeks immobilization, and 163 with 3 weeks immobilization. These groups showed a range of motion of 137, 129, and 131, respectively. And surgical treatment was done in 222 elbows, and showed the range of motion flexion extension 180 20 to 28 degrees. All procedures showed simple elbow dislocation were treated surgically and showed the range of motion of 90 degrees. And these authors concluding from this study that the early mobilization treatment showed the most considered satisfactory outcomes. And they have doubt about the surgery. And according to this table, non-operative treatment with early mobilization gets grade B, which indicates fair evidence, while operative treatment gets grade I, which indicates insufficient evidence, not allowing a recommendation for or against surgery. Here I present a case. It's a complex, it's not a complex case, elbow dislocation, which along with a fracture of the diaphysis of the radius. In this case, I performed the RIF for the radius. During fluoroscopy, the elbow was stable, so I didn't do any type of surgery in the elbow. 2 months, this is the x-rays, and this patient had a pain-free full range of motion, and he led back to his work. To conclude, a simple dislocation is not always a benign injury. With a supervised rehabilitation protocol, excellent functional outcomes can be obtained. And the overhead motion protocol is a safe protocol for unstable elbows. Thank you.
Thank you, Zinon, for your presentation. And now I would like to present Roger Van Riet from Belgium, Professor Roger Van Riet from Belgium, President of SECEC, that he will speak about indication for open or arthroscopic repair in simple elbow dislocation. We will see the video pre-recorded, and then we will have a discussion.
Hi all, my name is Roger Van Riet. I'm an elbow surgeon from Antwerp in Belgium, and I was asked to talk about indications for open or arthroscopic repair in simple elbow dislocations. I do have a disclosure. I'm a designer of this exosplint that is produced by Jake Design, and I'm also a designer with Acumed. When we're talking about simple elbow dislocation, we're talking about dislocations without associated fractures, and these are relatively common. They often occur from a fall in the outstretched hand, where patients support themselves and then rotate their body away. This was described by Driscoll in the 90s. There is another mechanism where there's a medial dislocation of the elbow as well, and this may be more common than the classic posterolateral that we're seeing here. When we're talking about simple dislocations, treatment is a closed reduction. We prefer this to do this under adequate sedation or a block, not to add to the trauma with your reduction. We then take the elbow through range of motion, and if there's no further dislocation or instability, without adding varus or valgus stress, without rotatory stresses, then treatment, at least in our hands, is conservative. We do get x-rays post-op. If they're negative, we're talking about a simple dislocation. However, if there's any doubt, the threshold to order a CT scan is very low. Conservative treatment of elbow dislocation is debatable. With regards to redislocation rates, it's probably sufficient to just give them a collar and cuff and get them moving as soon as possible. However, we still use this dynamic brace, as it does offer the patient a lot of support with regards to getting it moving and with regards to moving the arm. Conservative treatment usually leads to good results. However, Denise Agnew showed that after about 20 years follow-up, 45% of the patients still had medial laxity, and arthritis was quite prevalent in 40% of these patients. So when we perform surgery, we do this with severe instability. That means if there's a spontaneous dislocation with less than 30 degrees of extension, like in this patient, then surgery is definitely indicated. Like I said, we don't add varus or valgus stress, we don't test rotatory instability, nor lateral nor medial, just take a through range of motion, and if it dislocates spontaneously, it needs surgery. Other reasons for surgery includes profession, sports, and maybe arm dominance plays a role as well. And then if you decide to do surgery, this can be done open or arthroscopically. Now, what's the advantage of arthroscopy? First of all, diagnosis. You can evaluate the stability or instability quite nicely arthroscopically. For me, the indication for arthroscopic surgery is usually associated lesions, cartilage lesions, for example. Coronoid fractures are very easy to treat arthroscopically, at least minimal coronoid fractures. Radial head fractures can be treated arthroscopically, etc. You can repair the LCL complex, that's been tried and tested, and MCL. I know people are experimenting with the MCL fixation arthroscopically, but for me at the moment this is not indicated yet. This is a patient with an elbow dislocation, and you can see this is a simple elbow dislocation, but you can see the extensive damage that has been done during the dislocation. Cartilage of the trochlea has been damaged with a sort of an impaction fracture. MCL was ruptured. The cartilage at the back of the capitellum is gone. The extensor tendons are ruptured, and there's an LCL avulsion. Well, this can be treated arthroscopically quite nicely. You get a 19-gauge needle, PDS through it, shell it through the soft spot, so my grasper is in the soft spot here. So we're in the posterolateral gutter of the elbow, just to be sure. Then the second one is also in the stump of the LCL complex, can be anterior or posterior to it. I tend to grab them quite distally, because you'll see in a minute that we're pulling up the LCL complex quite high. So there's this is the same with open dislocations or open fixation. Of course, we use a all suture anchor. This one is a juggernaut, but you can use other brands like Arthrex or Smith & Nephew as well. So grab the sutures through the soft spot, make sure that you get all the PDSs and the sutures from the anchor together, take them out of the soft spot, and this is to avoid soft tissue bridges, and then you test your stability by pulling and tensioning the sutures from the anchor. There you go, so you get it quite nice and stable. And then at the end of this, I take out my camera. I don't put my camera back in after my fixation, because I don't want to tear anything that's been just been fixed with the LCL suture. So LCL repair is actually quite easily done arthroscopically. It's not a big surgery, and results seem to be fairly similar to open fixation. And like I said, the reason why I use arthroscopy is usually because of associated lesions, so cartilage lesions, blockage with rotation, for example, with a non-displaced radial head fracture, or smaller coronoid fractures that I think can either be fixed with a screw or with a lasso soft tissue technique. So this is the lateral side of the elbow. This was a volleyball player who landed on the feet of his opponent and then dislocated his elbow. You can see where the LCL complex has been torn away from the lateral condyle. We grab the center, usually put the anchor in the center of this condyle, of the center of the capitellum. However, in this case there was still quite a bit of stump left, so we decided to add this to our repair. The LCL complex, including radial collateral ligament and LUCL, is usually retracted, as you can see in the arthroscopic view. So I do pull the LCL a little bit up a little bit before suturing, and I make sure that the extensor tendons are included, because just suturing the LCL is a bit weak and has a tendency to tear out if you only suture the LCL separately. So I include the the extensor tendons together with the LCL complex. On the medial side, you palpate the ulnar nerve. I don't look for the ulnar nerve if I know where it is. If I can't palpate it or I'm really not sure where it is, then we do release it, of course. but in the majority of cases it's not necessary. As you stay anterior, we do flexor tendon split or over the top or Hotchkiss approach, or whatever you want to call it, but it's not completely a Hotchkiss the way we do it. I get the center of the extensor tendons and then go in, then blunt dissection onto the capsule, and you can see here where the MCL has been avulsed from the bone, and then there's a Z-type prolongation of the tear as described by Greg Bain. So the MCL is completely torn, and anterior to the MCL, the capsule tears away from the ligament. It's important to pull on it because it can be torn mid-substance together with the avulsion of the humerus, and it can also be torn from the ulna. If that's the case, of course, we use two anchors. You can use bone tunnels as well if you want to, or if you feel that's more appropriate for your situation. I don't think there's a difference between the two. The bone anchors are a little bit quicker, and for me in an acute repair, bone anchors are sufficient to fix MCL or LCL complex. Close the tendon split. You can do this through a relatively small incision, and as I said, no need to find the ulnar nerve. Here are some other examples. This is a basketball player. He weighs over 100 kilos, falls on his arm, has an elbow dislocation, as you can see there. Posterolateral elbow dislocation. Everyone knows it's dislocated. And this is his x-ray, so we're talking about a simple elbow dislocation in this case. We got a CT scan. Like I said, my threshold for CT is very low, no fractures. Actually, not bad congruency. However, he's a professional basketball player, so we decided to fix it instead of giving him 6 months of rehab and then finding out that maybe the stability is not enough. This is not surgical damage. This is from the dislocation, so you can see that the extensor tendons were torn away together with the LCL complex, and then on the medial side, the flexor tendons were torn away. Every time we talk about elbow dislocations there, we talk about the role of MRI. For me, MRI plays no role in my decision. So some people are doing some research at the moment to see if MRI findings can correlate with later instability, but for me, it doesn't play a role. So I do not get MRIs in these patients. This is a goalkeeper and youngest player in the Champions League ever, still is. And but when he was catching a ball, when he was stopping a ball, he ruptured his MCL just by doing that. So he fixed his MCL. This is just an image of the rehab. So because the fixation is so strong, we can sort of let them go. And in this case, the brace doesn't act as a stabilizer, as I said earlier, with the conservative treatment, but it does stop them a little bit in this case, because I didn't want him to go too fast with his rehab. He's a hockey player, and during a penalty corner, she hit the stick of. She was running into the stick of another player, and again tore the MCL. It's relatively uncommon to have an isolated MCL tear, but these two athletes tore their MCLs by a direct impact, basically. She had to go to the European Championships 10 weeks later, and she was able to play the whole tournament. And at the end of the tournament, they got bronze. So at the moment, she's been pain-free and injury-free for several years now, and hopefully will do well in the Olympics. So elbow instability, simple dislocation, conservative treatment in the majority of patients in my hand. Surgery depends on the injury. If there's a spontaneous dislocation before 30 degrees of extension, okay, we'll go for it. Arthroscopy, and obviously it depends on the patient, as I showed you a few examples. Arthroscopy for other intra-articular lesions, evaluation and treatment of them. LCR repair is quite easy to do. Coronoid, radial head, loose bodies, cartilage lesions, and then open, simple instability, no other lesions. I think open, there's still definitely a role for open repair of LCL with or without the MCL. Thank you.
So we have some questions from the audience, and Andreas, will you start one by one?
Yes. One question is from Dr. Watts, for Professor Watts, from Glasgow. It's about the timing of an MRI post-injury. Do you request it as an urgent examination, the first time you see them, the patient in the fracture clinic, or later?
Yeah, so in my practice, what we do is when they're seen in the fracture clinic, we pick up the phone, we speak to my radiology colleagues and tell them we've got a simple dislocation. We want an MRI scan within a week, and then we bring them back the following week to the fracture clinic. We normally keep them in a sling during that period, but we allow them to flex, extend pronation, supination as comfort allows, but generally advise them to not to do too much with the elbow in the intervening period. And then we have an answer for the following week as to whether we are going to do something further. If they're a grade 4 injury, if they're a grade 3 or less, then we just send them to the physios and let the physios take over their care. So we found that is effective. Obviously, we've engaged with our radiologists to get them interested in the injury, involving them in our research in the past. But again, I would emphasize that whilst it's an important injury, it's important for people to be aware of the management. We're not inundated with these. 3 in 100,000 is not such a common injury that it's going to swamp our MRI scanners. And for some people, it may be easier to take them to theatre than to do an MRI scan, and an EUA is a reasonable alternative to an MRI scan.
Another question from the audience for Professor Walsh is, can you pick the advancement of the tendons on clinical examination, aside from the bruising, as mentioned by you? And the comment is perhaps pain or resistant wrist extension, something like that. So can you examine the avulsion of the tendons?
So we haven't been able to find particular clinical parameters. I've mentioned that bruising just because it's an observation that I found helpful, and we haven't formally correlated that with the MRI findings, but it's just a clinical observation that I've made. But tenderness over the lateral side of the elbow doesn't seem to be relevant. I mentioned briefly in my talk, we found grade 4 injuries in people who were actually quite happy to move their elbow, and when we did an examination under anesthesia, they were wildly unstable, and so the patient who's sort of happy to move isn't necessarily reassuring. So we are trying to work out what clinical parameters are helpful, but at the moment we don't have high quality evidence for that.
Okay. And one last question for everybody. What is your opinion on ultrasound as a mode of ligamentous assessment post-elbow dislocation? This is a question for all.
I think this is the same generally. If it's exactly post-reduction, the patient has pain, so you cannot really examine it. That's why I always ask for CT and MRI. For me, it's standard because the patients come anyway after 3-4 days reduced. I don't reduce them myself, they come as a referral. That's why at the same, like in a chronic condition, of course, it's a great tool. But in an acute setting, I don't think you can do much. Of course, if you use it in an EUA, if you can use this instead of using the C-arm, could be maybe an option, but I don't use it.
Okay.
Christos, you describe all the classification system and you say pretty much details about this, but I would like to ask you, which is the most important thing for you from the medical history, some radiological sign or some clinical finding when you have an elbow dislocation? What do you take more into consideration?
Actually, everything. That's why I do all the diagnostics I can. So to get an idea what I'm going to get or how I'm going to proceed further. And what Adam said as well, if it's reluctant to move after a week, because I mostly see them after a week or 10 days. So there, I'm always prone to go to the surgical treatment, but of course I have everything, because for me a CO avulsion or avulsion of the common flexor origins plays an important role. So if I have a tendon avulsion or tear, I go ahead and I treat it surgically. That's why I do the MRI, actually.
Okay. I would like to ask Roger one question. You highlight the sport participation and the level of sports for going from conservative to surgical. I would like to ask if the age of the patient takes a role in your decision. If you have an 18 years old individual or a 45-year-old individual, do you think differently?
Yeah, it depends on the level of the athlete. It depends on whether they want surgery, yes or no. So I tell most of these patients that surgery is not necessary because many of them are not that unstable. And then I talk about the rehab, which has especially in athletes, it takes 3 to 6 months. And one of the things that we don't know in athletes is whether they can rehab properly and then be good in 3 to 6 months. So there will be, like Adam said, 10% of patients who may not regain full stability. And if they don't, then they've wasted 6 months. Whereas following the surgery, so far, I've maybe been lucky, but following the surgery, most of them, or all of them, have been able to return to sports. And rehab is not necessarily that much shorter, but at least we're pretty sure that they will do well after the rehab, because you just reinsert the ligament and sometimes the tendons in the right spot.
Christos, I have two interesting questions from the audience.
I mean, maybe first the questions from the audience, because I want to ask Roger like a question.
One is about the direction of the anchors, if they have to be perpendicular or in some kind of an angle. And another one is for Dr. Van Riet. When do you check if the patient dislocates in the last 30 degrees or not?
That's a good.
Okay.
Yeah, that's a good question. How do we test? I'm very lucky to work in quite a small hospital, so our line with the ER doctors is very, very direct, and they know that I want them to reduce it under. It's the same as Christos, so I don't see them acutely, so either they're reduced by the ER doctors or by our registrars, and they know that I want them to be reduced under sedation, and not just dry and just pull it and see what happens. So they need to be sedated, and then I want them to take them through range of motion. And they know this, and they do this. And if in the so like I said, 3 to 100,000 has an elbow dislocation, even a very small subset of that will remain unstable after reduction. And I asked them, and I stressed that a lot in the beginning of my career. Stressed that a lot, that I don't want them to do varus stress testing. I don't want them to do PLRI testing. I just want them to take them through range of motion, flexion and extension. That's it. And if they dislocate spontaneously, then they're very unstable. And if they are, then they get surgery, whether they're an athlete or not, it doesn't matter. And then there was another question for me. Let's see,
the ankles,
which patient?
The medial collateral ligament. So if you put the ankles in perpendicular or in some kind of angle.
No, I put them perpendicular to the surface, just anterior to the anterior apicondylar, medial apicondylar, sorry. So no angles, no specific angle.
Okay. So statement, can you see that? Doubtful plus minus 10 degrees, or like Adam mentioned, in the gray area. So they have different tests or thresholds to operate after evaluation of anesthesia. So if I make it very black or white, for Roger, I did not need to check the varus valgus. Adam will check the varus valgus during anesthesia. So what is right? This is more than a statement than a question.
Adam is always right.
Okay. And the last question
he's not listening. He's not listening anymore. He fell asleep, because otherwise he would really react to that.
Okay. So I don't think that we have any other questions here. I think it's only for the. Do you agree that the simple dislocation in the pediatric population is very rare and almost always associated with a medial epicondyle fracture? Do you have any experience with children? It's a question for all.
I think the medial epicondyle avulsion injury is a different beast. There's a trial currently underway in the UK looking at whether or not there's any benefit from early surgical intervention, and probably we need to await the results of that trial. But it's a different beast to a simple dislocation, I think.
And Manos, I think there's a last question.
I have a last one.
Yes, okay.
To Roger. When and how do you decide if you're gonna do it open or arthroscopically?
Yeah, that's a good question. I tried to talk about that in my talk. So I think open, there's really nothing wrong with open, and especially when there's a medial-sided injury, that I actually prefer to do it open. However, in some patients you have osteochondral lesions, you have fractures, you have associated lesions, and that's, for me, that may be a reason to do arthroscopy. There was one question I saw on the list: how do you know if there's an osteochondral lesion or there's a chondral lesion, really? And that's obviously a big question. All of my patients with small radial, I've not seen a big chondral lesions. Maybe I've missed them, but without blockage. So they tend to have blockage either throughout the range of motion, not necessarily that instability, or through rotation, just pronation, supination, passively. And when there's crepitus or blockage, there's something wrong, and you see that the tracking of the elbow is wrong. And I agree with most of you who said it's very difficult to do clinical exam in a patient who has just dislocated the arm, but it's almost always possible just to try to relax them and try to take them through a small range of motion until a certain degree of extension when you get some apprehension from the patient and they don't want to move. And that was not clear from I was just listening to my own video. That wasn't clear from my explanation. So the reason why we're still using these braces is not because of stability, not because we want to reduce the dislocation rate. And after all the studies that came out showing that the redislocation rate is exactly the same, I stopped using it for a while. But then I found that lots of patients lost confidence. And so I use it for confidence. The patient are confident, they feel like they're able to move, and they feel like they're happy to move with the brace on. And we block them to 60 and then 30 and then 0. And instead of coming to the clinic guarding the arm after 2 or 3 weeks, they come to the clinic and they say, look, I can go to 60. So it also motivates them. And I'm well aware that it's nothing to do with stability. And I also tell my patients this, and patients that are confident enough will take the brace off very quickly and they just start moving. But we did a study on this in over 200 patients, and 42% still wore the brace after I told them to stop it. So after 6 weeks, 42% still wore it because they wanted to be on the train. They went to the shop, they went to a party, and they loved the psychological aspect of it, I guess. But for me, I'm still confident that it helps. Not for the stability.
Okay.
Okay,
I think we finished.